opportunity to speak with you today about a very important topic that is near and dear to my heart, addressing health inequities through community health nursing practice. So I'll spend the next about 40 minutes just looking at different aspects that I think we can build our own capacity as community health nurses in Canada. We'll look at some of the learning objectives that's been defined by the planning committee for this event, the social determinants of health. We'll look at health equity itself. I have one story here that I would use to illustrate my point around our equity gap, the implications for community health nursing for equity, this equity gap. We'll also look at community health nursing in Canada blueprints for action. We also talk about mobilizing community through participatory action research process, and I would use an example from my own study, and I will finish up with some conclusions about this approach to building community capacity. So in terms of the learning objectives for this presentation, I'm hoping that at the end of this, we'll be able to describe how the determinants of health play out among vulnerable populations. We will discuss the potential contribution of community health nurses to reducing health inequities in Canada. We'll also describe the potential contribution of communities in terms of health promotion work. So the social determinants of health. Clearly, over the past 50 years, health researchers and practitioners have developed better understanding of the many factors that prevent chronic disease and lead to good health. Unlike previously, when health was primarily viewed as a matter of biomedical cause and effect coupled with negative lifestyle choices, we now understand the ways in which our social environment shapes the decisions we make and the environment or behaviors we engage in. I would just quickly look at the social determinants of health as defined by our own Health Canada. When you look at some of the work, even in Public Health Agency of Canada website, these are the key areas that have been identified as some of the factors that determine health. So gender, health services, employment, working condition, income and social status, education and literacy, social environment, culture, social support and networks, personal health practices, coping behavior, and physical environment. And I would add my own factors like racism, discrimination based on other things, whether it's based on age and class, all also contribute to poor health in the population. So health equity, as Michael Momo would say, these social conditions in which people live interact to powerfully influence their chances to be healthy. Health is closely tied to the environment around us, where we live, work, learn, and play. These inequities are not inevitable. And as I illustrate with this cartoon here, this person lying here said, we've run every test we could think of, and the results show that you are out of money. So you can keep coming to the hospital, but the real problem is you have other issues, including money, that's costing the return visit to the hospital. And even in our own Canadian literature, where I would say walk around this issue is still in its infancy stage, we have a number of studies that have shown disparities between population, disparities along racial lines, along income lines. We're seeing that more and more. There's an example here of a study done by Zhong Sheng and colleagues that looked at disparities in birth outcome among Inuit people. We've also had a study by Smiley in 2010 that looks at disparities in indigenous people birth outcome here in Canada, in the US, and Australia. So there was comparison done in these three countries. I'm not going to go into each of these studies, but just to point to illustrate that even here in our own Canadian system, we're beginning to see these disparities. And some people describe this as disparities, others use terms like inequalities to describe the differences in health status. I prefer in Canada more and more we're using equity to describe that, because when you talk about equity, then you're acknowledging putting a judgment call on it. That is an unfair difference. It's not just a difference between people that have equal advantage. It's a difference that is based on some kind of injustice or unfairness between the two groups. One person being in more position of disadvantage and another in more position of advantage. We also have the study by Noor that looked at racial discrimination and depression among Asian refugees here in the Canadian context, and another one that looked at the social determinants of health in immigrant population. I've done studies myself, including one that looked at maternal child health challenges within immigrant community that again talks about the impact of systemic barriers like racism. I put another study here, actually write one of my papers looking at racism in healthcare, the experiences of childbearing women of African descent. So these are just examples to illustrate that those disparities we're talking about is present here, right here in Canada, and we can do something here in our own country too to address it. So this health inequity, of course, is also present at the global level. So health inequity at the global level, when you look at some of the statistics we're seeing, even through CEDA here in Canada, you see that each year more than 7.6 million children die before the age of 5. And today, there is a 36-year gap in life expectancy between countries. For example, a child born in Nigeria can expect to live for 47 years, while a child born in Japan could live for as long as 83 years. And that's from WHO stats. So you can see the significant difference between countries, just like we have between communities, even in our own local environment. And I use this Jason story, which is a story we've had for a few years now on PHAC, or Population Health Agency of Canada website, that illustrates the story, this young boy story, Jason. So I'll just go over Jason's story. So Jason is a young boy who went to the hospital because he had one infection. And the story goes, why is Jason in the hospital? Because he has a bad infection in his leg. But why does he have an infection? Because he has a cut on his leg. But why does he have a cut on his leg? Because he was playing in the junkyard next to his apartment building, and there was some sharp, jagged steel there that he fell on. But why was he playing in a junkyard? Because his neighborhood is kind of run down, a lot of kids play there, and there is no one to supervise them. But why does he live in that neighborhood? Because his parents can't afford a nicer place to live. But why can't his parents afford a nicer place to live? Because his dad is unemployed and his mom is sick. But why is his dad unemployed? Because he doesn't have much education and he can't find a job. But why? And the why continues. As you can see, Jason's story links the many determinants of health, the 13 determinants of health we've talked about. You can see how poverty, poor housing, can lead to a physical condition such as a cut on the leg and the subsequent infection that brings Jason to the healthcare facility. And so as community health nurses, we actually deal with people like Jason so they don't have to even get to the point of going to a hospital. And so when we see even a young child or somebody with a physical condition that goes to the hospital or being returned back to the community, I think we really have to understand the root causes of the problem in the first place, so that, especially for us as community health nurses, we can continue to advocate for these kinds of conditions to be prevented and for health to be promoted. So this seemingly simple story of Jason suggests that health is influenced by a number of factors. These factors interact with one another to affect the health of Canadians at various levels, individuals, communities, and even that of our whole nation. The key driver of equity, as Michael Momo, one of the top the leaders in this dialogue globally, says, that equity is a toxic combination of poor social policies and programs, unfair economic arrangement, and bad politics. That's what's responsible for the fact that the majority of people in the world do not enjoy the good health that is biologically possible. And so what implication does this have for us? And I start again, as Michael Momo says, that actually that is in his 2011 articles, that social justice is killing us on a grand scale, again referring to those conditions or inequities that exist between communities and nations and regions, that exist even along racial lines and along gender lines. So community health nursing practice, as you've clearly stated in your own, in the community health nursing blueprint for action, that the community health nursing practice occurs at that intersection where societal attitudes, government policies, and people's life meet and create moral imperative, not really to attend to the health needs of the public, but also, like Nightingale, to work to change societal conditions contributing to poor health. That is, to engage in social justice. And so, clearly, part of our work as public health nurses and community health nurses, whether we work in home care or in public health, is to engage in social justice work. The blueprint for action also calls nursing to take a lead in the redesign of the healthcare system. Says community health nursing has an important position in healthcare system, and its voice is critical as Canadians search for solutions to challenges facing the healthcare system and their health. And the time for action is now, and many opportunities are available as we engage in the dialogue to create change in healthcare. Community health nurses have a significant role to play because we have a close proximity to the communities. We work closely with the people in the community, whether it's in time of emergency, in time of disasters like SAR, we're there leading in immunization effort. Whether it's for pregnant women, we're there. Whether it's for our aging population, community health nurses are there addressing those needs. Whether it's for people who have chronic conditions like high blood pressure, diabetes, community health nurses are right there working to prevent that situation and to manage even the around policies that might affect that and advocate for those kinds of policies. And I look at this community nursing Canadian community health nursing standards of practice as again leading us, showing us the way in terms of addressing equity and increasing access, so building our own capacity. I look at these different standards and I can see how this links to equity work. So in our health promotion, in the prevention of health and even the protection of health, even in health maintenance and restoration, we need this order that's supporting standard in the outer circle, like the access and equity, the capacity building, the professional relationship, professional responsibilities and accountability are all key components that comes together to really create a strong focus on reducing that equity gap between populations. And I just thought I picked on a couple of those standards to just illustrate how we as community health nurses can really contribute through these standards that have been outlined for us, how we can implement work according to these standards to really address equity in community health and among our population that we work with. So the first standard here involves the process of community mobilization based on evidence. So that we use our own research that we create to foster empowerment and deal with health equities and to promote physical activities if that's the way the particular research around that, but also even in just to participate in regular social activities using the current evidence that we have. Later on in the presentation, I would use my own research to show and to illustrate an example of how research can be a strategy to create an empowerment in the community, but also to advocate for changes beyond what community members themselves might necessarily know where to go. But we as nurses, we're kind of the link, because we know the community now, but we also have the networks that would place us in different committees where the community voices might not necessarily be heard, and we can advocate for those voices to be heard. So in terms of capacity building, that's the standards number 5. Community health nurses are not only uniquely positioned to build relationship with those who have health needs, they also have the expertise to act as advocate, which is the point I was making, to act as advocate and liaison with those who distribute resources. That's the network we have. Community health nurses build on established community resources and strength. We as community health nurses also build capacity at the individual, organizational, and whole community levels. We also are able to collaborate. So as nurse leaders, we need to collaborate. We need to collaborate to develop strategic partnerships that would give voice not only to community health nursing, but to mobilize the resources necessary for the development of both workforce, but also for addressing some of the challenges we face in our work. It takes the combined effort of networks both within and outside the public health system to address population-wide health challenges. And so we have to mobilize those resources and mobilize their collective effort from our networks to do that. And so one of the examples I would like to share with you is about a research study that was conducted in Nova Scotia. So the purpose of that study was to investigate the health status, healthcare delivery, and health service utilization among African Canadians living in rural and remote regions of Nova Scotia. Another objective was to build community capacity of the Black community people involved in this study, so they can look at the health research through this collaboration and networking. And it was an academic and policy in terms of government, Ministry of Health, and also academic community collaboration. So we had academic researchers, we had people from policy background working with the government, and we also had local people in the community coming together to develop this project. It was a mixed method study, mostly qualitative in nature. So the sample included 237 Black women over the age of 18 that were interviewed. We had 3 community facilitators who helped in conducting the interviews covering 3 counties in southwestern Nova Scotia. Participatory action research formed the guiding tenet for the study. The study was a 3-year study and started with a very diverse team, not only from the Black community, but from the academic setting and non-governmental organization as well as government. So the action research, participatory action research is a strategy for building community capacity, because it is not only an approach to investigating a phenomenon from the perspective of those being studied, it is also a means of mobilizing for collective social action to address the community needs. and for creating change at multiple levels. So you see change, transformation happening within individuals as they become more passionate, as they learn more about their particular situation, the issues that or factors that influence their situation. People feel this sense of empowerment. There's a transformation that happens inside, and you see the passion building as they engage with each other, ready to create a change in their situation. But that transformation happens at the individual level, but also is transmitted even to the community level as people meet together to try to create a change in their situation. And so that filters up into different levels. So the principles of power values what people know and believe by using their present reality as a starting point and building on it. It creates critical awareness and subsequent transformation. It fosters empowerment through the process of engaging in experiential learning and collective action. So all people, Power's principle believe that all people have the capacity to think and work together for better life. Knowledge, skills, and resources are to be shared in equitable ways. Authentic commitment towards the shared goal of social transformation is required at all levels, from individual to the system level. So some of the distinguishing features of power process is that shared ownership of the project. So individuals with a common goal coming together to work to form a group with a specific purpose. It offers an opportunity to not only choose the issues to be explored, but also a chance to take collective action for social change. Community-based analysis of the social issues is also something that is integral in that process. So the continual dialogue supports the development of a climate of mutual trust, of a climate of openness and cooperation. So again, in this particular project, some of the capacity building opportunities we had included developing this collaborative partnership between the university and the community organizations. But also we provided training programs for the community facilitators. It was a way of demystifying the research process so that those people who came from the community require specific skills that would allow them to engage with our data completely, and we needed to provide some of those. We knew we could not provide those courses ourselves, and so we collaborated with a local community college to design and implement customized certificate programs. So people got certificate in ethics and professionalization, professionalism, conflict resolution, interpersonal communication, media communication, stress management. It was interesting because we saw the community facilitators just blossom in terms of their professional growth right before us as they went through these courses. They were also very happy because actually provided them with certificates to show that they've gained these new certificates or skills and accomplishment. So team members also designed and implemented workshops for the facilitators on data coding and analysis, use of qualitative data analysis, computer software, dealing with trauma and racism. We also collaborated again still with the community college to design and implement courses in public speaking and presentation skills, Microsoft Excel tips. That was what we used at that time, computer troubleshooting skills. And it was interesting because when we first started this project, we had team members who were intimidated and just were afraid to even think about doing PowerPoint presentation. But we saw such growth. By the end of our project, we had team members who were prepared to run for political offices in their local areas. Some of them joined their community health boards and could begin to advocate for issues affecting Black women's health in their regions. So it was just fascinating to see the change that happened as these women went through these courses. So some of our project outcomes, we saw increased richer skills and sense of empowerment. We saw greater knowledge of the Black community and women's health issues, mobilization of Black women to participate in community health events, including sitting on those health boards. And some of them even had like an event in the community where they go for Black women's health walk, prepare t-shirts for this kind of event to mark the need for more activities to facilitate health in their community. They also joined in the creation of an African Canadian Health Information Manual that is still being used as a resource and referral material for people to do their quick references with. The creation of a play based on the research finding. It was just interesting because at the end of this study, we were amazed when the community facilitator from one community told us that when we did the presentation, we had a press release about the study. They were going to act a play, and they used the findings of the study to create a play. They wrote this play. One of them had very good writing skills and wrote out the play, and they acted this beautiful play that was acted in a number of public theaters in the province. Another community decided to develop an educational quilt using the study findings, and they developed this quilt using the study findings, but also applied to their community health board for funding to design a wheel and a stand with wheels where this quilt was displayed on, and it traveled around the province from different offices, and that quilt currently is being displayed at the Housing University in the Department of Social Work. So it was just really interesting to see even the innovative ideas these women came up with in terms of the knowledge translation piece of our study. So what have we been able to, can we say we made a difference? Well, the feedback from the community says that the partners, the people in the community were satisfied with the research. Community facilitators were satisfied with their activities, especially the capacity building initiatives. Another question we'll ask ourselves is, did learning occur as we intended it to? Well, I use narrative notes here from the facilitators to illustrate that point. One person said, I have a better understanding of the women in my community now. Another one said, I have learned how to do good interview and code data, so they know the research process, they understand the issues in their community. Another question is, has learning been applied to their work? One woman said, when we asked them these kinds of questions, said, giving women a chance to tell their real story was a good way to get information. And now she understands how she can continue to encourage women to tell their stories, but also how they're using this as leaders in their community, how they're using this information to advocate for changes. So in conclusion, I'll say PAR, the community empowerment occurs through this, because PAR approach honored the lived realities and the experiential expertise of partners, as well as the creativity embedded in a collaborative process. The indigenous knowledge of the community facilitators was vital in enabling the team to better understand the barriers and challenges affecting Black people's health in these communities. Knowledge exchange between the academic and community researchers was instrumental in building capacity of both groups. So PAR is a means to eliminate inequities, including barriers to appropriate care through community empowerment. In summary, health starts long before illness, in our homes, in our schools, even in our own workplaces or jobs. Canadians should have the opportunity to make the choices that allow them to live a long and healthy life, regardless of their gender, income, education, race, or ethnic background. Our neighborhood should not be dangerous to our health. Our opportunities for health starts long before we need medical interventions. And our opportunity for health begins in our families and communities, in the presence of community health nurses. And so we as community health nurses need to work closely to ensure that equity exists in our communities, to ensure that health promotion is a thing of reality for people irrespective of their background, whether it's poverty or race. As community health nurses, we must embrace that work at the intersection of this where social justice meet the community or meet the people that we work with. So I would like to conclude by saying that the reality of healthcare is constant change and that there is nothing in the near future to reverse the direction of change. As a community health nurse, do you want to be the master of these changes or do you want to be the servant? I thank you for listening to this presentation. Unfortunately, I'm not here to take your questions, but you can send me an email at jaitoa@uottawa.ca. Thank you.